Everyone, today we'll be discussing about the approach to abdominal distension. So coming to the abdominal distension, so many people will come to with the complaint. First thing you discuss it when you talk about abdominal distension, I know you will be going to try to think about ascites, but there are other causes of abdominal distension that can be just flatus or any intestinal obstruction or any mass can be there. So you need to keep all of this mind before, like most of the cases in RIP and OP based in medicine are mostly related to the fluid retention. But there are other causes like any in pregnancy it can be related to fluid due to the ascites or cyst, that can be ovarian cyst or anything, any flatus, abdominal distension, any fat per se, visceral fat accumulation can be there, any intestinal obstruction can be there. So these are all the possibilities, especially this ascites are ascites is the most common cause. Coming to the abdominal distensions, so most of the patient, especially who are lactose intolerant or who are anxious patients and all, so they'll have some irritable bowel syndrome, so that can have aerophagia and all, that can have abdominal distension and bloated like symptoms. So in them you advise them to avoid this lactose foods or lactose containing foods, and also food map diets are which contain high amount of fructose like mango should be avoided, apple should be avoided, and high fructose containing maple syrup should be avoided, any lactose containing milk products should be avoided. So you should advise low food map diet in those patients, and also lactose containing foods in those diets in those patients. So that is mostly related to the bloated symptoms, and also sometimes intestinal obstruction. Always better to get an X-ray rectal abdomen to look for any intestinal obstruction. That can be due to many causes, that can be due to post surgery, that can be due to underlying stricture or obstruction or carcinoma. Anything that can be obstruction should also be ruled out in the case of abdominal distension. So always keep in this mind from basics, always you need to rule all of these causes before going into the evaluating the abdominal distension. So a 60-year-old female presented with the complaints of abdominal distension, has a history of weight loss, and also she is a non-alcoholic and no melena. So first thing when the patient comes to with say abdominal distension, first our mind goes to liver. So we always think a chronic liver disease is a possibility in almost all cases. So most of the chronic liver diseases in our present setup are mostly not alcoholic per se. NAFLD. NAFLD has become a very common reason for the cirrhosis in our modern world. So that can be a possibility. First thing, always look for the BMI. Always look for any metabolic syndrome features are there. If there is any hypertension or diabetes is there, any dyslipidemia is there, get an ultrasound to look for any fatty liver. Always better to look for NAFLD features also. So it's better look, but then you get an abdominal distension is there, but weight loss history is there. She's a non-alcoholic. One possibility is NAFLD, which we are working up. She has no melena also. So generally, most of the CLD patient when they have ascites, they'll have some bleeding manifestation like variceal bleeding or something. So melena might also be a possibility, but that is not there in this case. So, but the patient has abdominal distension and has weight loss. So any elderly patient that is coming, elderly or younger females also who are coming with an ascites, and if the ultrasound is showing septation, thickened septation, one thing you need to think about is whether it is a TB or a tumor, pelvic tumor, that is ovarian tumor, that Meek syndrome is there. So that is a possibility. So any elderly patient always think first in a malignancy, then tuberculosis is a possibility, especially when septations are there or weight loss history is there, when CLD is not a possible in that case. So this might be an abdominal distension secondary to some ovarian tumor, which is common at this age. So sometimes Meek syndrome is a possibility because of underlying weight loss and all. And also TB is also a possibility. They'll have different manifestations. So then you need to do, first you will get an ultrasound abdomen to look for any NAFLD, and also pelvis to look for any pelvic adnexal mass are there. If the pelvic adnexal mass is there, then you go ahead and do an FNAC and biopsy and to diagnose epithelial, and also get an ultrasound ascitic tap also, which will you will find malignant cells also in the that pseudomyxoma peritoneum are all there, and you can get a malignant cells and from the uh, peritoneal fluid also. In them, the difference between the CLD and this is that generally they are low sag. So generally whenever you're doing the acetic fluid, you use serum acetic albumin gradient. If it is high sag, if sag serum acetic albumin gradient is more, that is suggestive there is a portal hypertension. So if the low sag is there, the portal hypertension is not the cause. So it can be due to the nephrotic syndrome, it can be due to the any metastasis like any peritoneal metastasis or something, it can be due to tuberculosis, it can be due to the any pancreatic causes and all. So they are all possibility. So in order to differentiate of all of this, you need to get a protein also. So general nephrotic syndrome protein will be low, and also get a malignant cells for any peritoneal mets or something, MLH levels or pancreatic, bilirubin levels for biliary. So tuberculosis you mostly find ADA level elevated. So ADA levels are elevated in them, and most of them are TLC count is very high, which is lymphocyte predominant. So if you get an ultra ascitic fluid analysis, if malignant cells are negative in this patient, get a TLC count. TLC count will be elevated with lymphocyte predominance and ADA levels are elevated. That might be ADA. That might be a tuberculosis. Might be a diagnosis with underlying lymph nodes and all. So in them also, if the tuberculosis, get an X-ray done to look for any pulmonary TB, and also Monto test needs to be done. So I'll discuss about how to interpret Monto later, and also IGRA. Presently outside IGRA, interferon gamma releases is also being done. So if the features are suggested, you can directly go ahead and treat with TB. And most but the patient, for confirmatory diagnosis, you need to get a peritoneal biopsy. Even the pleural fluid also, they're insensitive. For peritoneal or pleural TB, it's always to get a biopsy. Pleural biopsy or peritoneal biopsy is the gold standard for diagnosing tuberculosis in such patients. So in this patient with complaints of abdominal distension and weight loss, first diagnosis is always a malignancy. Then tuberculosis is also a possibility. So based on malignant cells and other ADA levels, you can work up further. A 40-year-old male known case of alcoholic present with complaints of pain abdomen and abdominal distension. So this is a alcoholic present with pain abdomen and abdominal distension. Let's say this is a short history and all. So there's a known cause of alcoholic. One thing always an alcoholic, you think chronic liver disease is a possibility. First time presentation of decompensated chronic liver disease is a possibility. Then other thing is a pancreatitis. So pancreatitis can also cause ascites in this patient where we use octreotide and all. So the difference in management, in the CLD you give generally salt restricted diets, and aldactone we give, and then followed by fluid restriction is what we manage in the case of CLD. Whereas in the case of pancreatic ascites, you advise octreotide in the case of them. So how do you differentiate in the chronic liver disease related ascites and pancreatitis ascites? Generally, chronic liver disease is mostly high SAG, whereas pancreatitis is low SAG with MLS levels being elevated. MLS will also be elevated mm, in the case of pancreatic ascites. So that is one more thing that is a possibility. So in this patient, if it is acute onset, always look at pancreatic ascites with the imaging. Ultrasound should be done, CEC to be should done. Also amylase levels in the ascitic fluid also needs to be done. And the case of SAG ratio also will help you in differentiating. A 30-year-old male known case of smoker and alcoholic present with the complaints of pain abdomen and abdominal distension, which is acute in onset with SAG ratio of 1.3 and protein of 3 gram per deciliter. So this might be a case of 30-year-old male, known case of smoker is there, and alcohol, he is also an alcoholic with complaint of pain abdomen. So generally in the case of pain abdomen or tender abdomen is generally seen in the case of any viral hepatitis or congestive hepatopathy is where we see tender hepatomegaly, where you when you are palpating also you will find pain, especially in the congestive hepatomegaly. So there is a pain abdomen and abdominal distension. Let's say the tenderness is there on the palpation also. Then the first thing that you should become is a congestive hepatomegaly that can be to IVC obstruction or heart failure or anything. So then most of the CLD patients will have shrunken liver. The liver won't be enlarged. In the congestive hepatomegaly, the liver size will be preserved mostly. It won't be shrunken and all. So that is a differentiating point because both heart failure or post heart hepatic any IVC obstruction or something or a CLD patient all will have high SAG ratio. But how do you differentiate between the heart failure and CLD? Is one thing is in the case of CLD, high SAG, low protein is there. In the case of heart failure, high SAG, high protein will be there. But also sometimes because of the persistent heart failure, sometimes cardiac cirrhosis is also a possibility. So in them, high SAG, low protein is also a possibility. How do you differentiate between them? Is one is protein, other is BNP levels. You can do brain natriuretic peptide levels if they're elevated. Mostly heart failure related ascites is a possibility. So that is one more thing. So here in this case, the patient has pain abdomen. Let's say tender hepatomegaly is there, abdominal distension is there. So SAG ratio is high, protein is also high. First thing you need to look at this because both high SAG and high protein is there. First thing any congestive hepatomegaly because of heart failure is a possibility in this case because a known smoker and alcoholic. Though is an alcoholic, CLD is a possibility. But if chronic liver disease is there, then high SAG and low protein are there. And then one more thing, if the patient is a smoker, always check in hemoglobin. So if hemoglobin is more than 17.48 polycythemia is there. So in that patient, because of polycythemia itself is a prothrombotic state, sometimes Butcher is a common presentation. Butcher is one of the common presentation of uh, Butcher is a common presentation in the case of polycythemia patient because it is a prothrombotic state because of the increased viscosity of the blood. So in them you need to do phlebotomy and all and also put them on aspirin. So always in a smoker, always get a hematocrit levels and also get a hemoglobin done. But hematocrit has a major role in them. So if the polycythemia should also be in the bed area because Butcher is a possible presentation that can also present with pain abdomen and ascites. So in them, though it is mostly looking like an heart failure, CLD is unlikely because as protein is normal. The one more possibility I'm thinking is because smoker polycythemia is a possibility. Then you can look for the any hematocrit elevation is there. Then polycythemia can cause Budd-Chiari. Budd-Chiari can cause like hepatomegaly and ascites. So then you need to put them on a phlebotomy and also aspirin prophylaxis and also heparin initially for the if the acute butt share is there. So this might be a case of acute butt share also. In the case of late butt share, the patient will go into cirrhosis. This protein also will come down. So early butt share will have total protein high, late butt share will have total protein low. So always remember this: the more near the lesion to the liver. So let's say like the butt share syndrome or any post sinusoidal obstruction is there. In them, the predominant symptoms are always ascites. When the patient, when the problem is near to the spleen, let's say extrahepatic portal vein obstruction, in the patient who won't have ascites much, they'll have splenomegaly and variceal bleeding much. So more near to the spleen, the lesions will be more of bleeding and also splenomegaly. More far away from the spleen, more like post sinusoidal or any IVC obstruction or heart failure, they'll have more ascites when compared to splenomegaly or bleeding manifestation. So always remember this. So in them, three possibilities: one is any butt cherry, the next is heart failure, the other is serious CLD. So a 50-year-old female underwent cholecystectomy procedure, developed abdominal distension and ascitic fluid, showed dark colored fluid. So one of the thing is most of the cases asset is always seen CLD, but they have kept different scenarios. Let's say abdominal distension is there post cholecystectomy. One thing is bile duct injury. So bile duct injury can cause biliary leak, that can cause biliary ascites also. So this might be a case of biliary ascites. You can measure the biliary levels in the ascitic fluid and can diagnose the biliary ascites. So you repair the duct and biliary ascites is very irritant to the ascitic peritoneal membrane. So biliary ascites is a possibility in this case. So a 40-year-old male has a high developed weight loss and has an abdominal distension. Aesthetic tab showed low sag and high protein and multiple lymph nodes and septations on ultrasound. So is a 40-year-old male has weight loss and has developed abdominal distension. Aesthetic fluid showed low sag. So low sag, it's CLD is ruled out and heart failure, portal hypertension is ruled out. So low sag and high protein. So high protein is generally seen in the case of tuberculosis and infection is there or malignancy is there. Multiple lymph nodes and septations. So first thing, always septations are there. One is pseudomyxoma peritoma is possible. TB is also possible, and also multiple lymph nodes. So the tuberculosis or malignancy is possible in this case. So always get lymph node if possible. Get a if tappable, get an ultrasound guided FNAC biopsy of the lymph node is possible, and check for ascitic fluid analysis for ADA levels. If there is any leukocyte lymphocyte predominance in the leukocyte, and also get any malignant cells are present in the ascitic fluid is there. And also like for other signs of tuberculosis in the pulmonary TB, IGRA needs to be done, MON2 needs to be done in this patient. And also look for other multiple, if there is cervical lymph nodes are possible, get them examined also. The lymphoma also can sometimes cause ascites. And also look for any pelvic tumors that can cause this. Even malignant melanoma can cause ascitic fluid, and pericardial fluid and ascitic fluid can cause malignant melanoma. That is also will be dark color like biliary. So malignant melanoma can cause pericardial effusion and also ascitic fluid effusion. So look for malignant cells also. So this might be a TB or malignancy in this case. A 20-year-old boy developed abdominal distension and ascitic fluid showed white color fluid. So generally, based on the color, you can tell what kind of ascites is there. Generally, straw colored or is there. Generally, it is can be normal CLD. Sometimes it can be seen in TB. Can have anything. Straw colored can be there. Hemorrhagic can be there in the case of TB. And also sometimes a brown dark color is seen in the case of biliary pancreatitis or any malignant melanoma. And sometimes that thick like pus like fluid can be seen in the case of infection and all. And most of the malignancies will have either hemorrhagic tap or something. So if white color fluid is there, first thing you think suspect is chylous effusion. So chylous effusion can be a possibility that can be due to the chylous and pseudochylous, both are there. So chylous in the, how do you differentiate in chylous and pseudochylous? Chylous is pure chylous is mostly due to the chylomicrons. Chylomicrons will levels will be more than 110 in the case of chylous, whereas pseudochylous is due to the some TB or something where the chylomicrons will be less than 110, and in them cholesterol will be elevated. But chylomicrons will tell you whether it is a true chylous or pseudochylous. Chylomicrons more than 110 is suggestive of chylous, whereas it less than 110 in the case of pseudochylous. So that can differentiate. But chylous effusion can be seen due to the trauma to lymphatic duct or some congenital causes, or filariasis can cause chylous effusion. So you need to work up in that line. So but always prove whether it is a chylous or pseudochylous first. So these are the first thing. Abdominal distension, always first thing you need to look for the dietary factors are there, like if it is a fade, if there is any obstruction is there, flatus is there, fecus is there, or also any fluid is there, that you need to work up further. But let's say abdominal bloating and distension are the first symptoms. Always look for any dietary culprits like listic lactose and fructose content, like high FODMAP diets should be restricted, and gluten-free diet should also be followed. If constipation is present, always look for any, you can give any laxatives or high fiber diet should be advised. And also if there is any pelvic floor disconnection, you need to send them for the biomedical training needs to be done in the patients of them. So they'll train the patients how to relax the sphincter and how to pass the stool. And if there is any SIBO, especially SIBO is seen in the case of hypothyroid patients and diabetic patient or chronic CLD. All the CLD patients and hypothyroid patient will have SIBO, small intestinal bacterial overgrowth, which is the small intestinal migration of colonic bacteria. So SIBO is a possibility. Should do a hydrogen blood test. As I mentioned in the previous videos, hydrogen blood test, you ingest lactose and glucose. If the generally peak of hydrogen blood test will be seen after 2 hours, because colon bacteria will degrade it. If it is seen less than 90 minutes, that is suggestive of migration of bacteria is there into the small intestine, that is causing peak more than 20 ppm in less than 90 minutes. That CVI is a possibility, especially hypothyroidism, scleroderma, diabetes, and also chronic liver disease. So they will all have SIBO manifestation. And always if there is any visceral hypersensitivity, especially irritable bowel syndrome symptoms like IBS-C and IBS-D, where they will have infrequent diarrhea, will they have they'll have like pain abdomen. If they pass a stool or something, they'll have subsiding of pain abdomen, and no nocturnal symptoms will be there. Some psychiatric manifestation like anxiety or something will be there in the background. So in them you can try neuromodulator like any SSRIs can be tried, tricyclic antidepressants can be tried. So read about I already mentioned about IBS symptoms, Rome criteria, where they'll have frequent variation. Constipation, diarrhea will be there at least 2 times a week or 2 to 3 times a week, and they won't have any nocturnal symptoms like pain relieved on defecation. These are all symptoms of IBS, and they have some functional disorder like psychiatric disorder will be there. So these are the various possibilities in this case. Always correct all of these factors. There is abdominal bloating and distension in this patient. First, dietary should be advised. If there is constipation, correct it. If there is test for SIBO in the case of CLD, diabetes mellitus, hypothyroid patient, and also scleroderma patient, check for any IBS symptoms in all the patient, and also then any dyssynergia that can be, that is the last possibility. So this is the SAG. First you check for the high SAG ratio, serum acetic albumin gradient, and then if the high SAG is there, then low protein. If the low protein is there, that is suggestive of cirrhosis or late bud cherry or massive liver metastasis that is affecting the liver function. So per se low acetic protein is suggestive of the liver function is affected. So high SAG, low protein, cirrhosis, late bud cherry, and massive liver metastasis. If high SAG, high protein is there, that is suggestive of heart failure or pericarditis or early bud cherry or IVC obstruction or sinusoidal obstruction syndrome. So these are all possibilities. Heart failure can be due to the right heart failure mostly. Constrictive pericarditis can be due to TB or TB is the most common cause. Then early bud cherry, secondary to any prothrombotics, the most common polycythemia is a possibility, or any a factor V Leiden mutation or a protein C protein S deficiency. All you need to work for prothrombotic workup and all. IVC obstruction is a possibility. Sinusoidal obstruction is generally seen in the post bone marrow transplant patient, and also who are on the cyclophosphamide melphalan like drugs. So sinusoidal obstruction is generally seen post bone marrow transplant patients. So generally high SAG is low. That is suggestive of the portal hypertension is not there. First you need to look for biliary look. Nephrotic syndrome, protein also will be low. Pancreatitis, any metastasis, and tuberculosis. So these are the various, how do you work up for the ascitic in the case of them. So then cirrhosis, TB, these are all the various things. Cirrhosis generally straw color bile stain will be there. Protein will be low and SAG will be high, and WBC will generally less than 250. TB generally turbid or sometimes chylous can be there. That can be pseudo-chylous and all. Sometimes clear, straw colored, anything. Hemorrhage can also be possibility. Generally protein will be high and SAG will be low. And generally they will have lymphocyte predominant, generally diagnosed by peritoneal biopsy. Whereas pyogenic turbid or purulent will be there. SAG will be, protein generally will be low, not much high in the villain. Sometimes can be high also if there is significant inflammation. And SAG will be low. Generally WBC will be predominant in neutrophils. Significantly gram positive staining also will be positive. Always gram positive blood cultures needs to be done, and also significantly predominant. More than 10,000, more than generally leukocyte will be generally very high, and there is significant neutrophils will be there. And congestive cardiac failure, generally straw colored, protein will be generally high SAG and high protein will be there. Sometimes the significant albumin is per se low, obviously protein also will be low. So in these cases, and WBC will be low and all. Pancreatitis, you always check for the amylase levels, and neoplasms always high SAG and low SAG and high protein. Protein will be very high in this patient. So especially pancreatic and neoplasms protein will be very high. So always check for these causes. So straw colored in the case of normal cirrhosis, TB, bloody in the case of TB, pancreatitis, perforation, any malignancies and all. milky chylous ascites, dark brown biliary, black in the case of pancreatic ascite like pigmented and malignant neoplasm is possibility. Any dark colored always biliary, pancreas and malignant melanoma should be suspected. Bloody TB malignancy is the first thing that can go, any visceral organ damage. So this is normal less than 250. Uncomplicated cirrhosis generally will have less than 500 and ANC less than 250. If ANC is more than 250, absolute they suggest of spontaneous bacterial peritonitis. So polymorphic neutrophils more than 250 suggest of spontaneous bacterial peritonitis. And TB generally lymphocytic predominance will be there. High TB lymphocytic predominance will be there. And also RBC count also will be on the little higher side, and ADA levels can be done in this patient. Lymph nodes will be there. Sometimes septations might be there in this patient. Sometimes other extrapulmonary manifestations also needs to be checked. And intestine can be intestinal manifestations like ileocecal TB can also be there in these patients. So this is chylous and pseudochylous. Chylous more than 110 triglyceride levels, pseudochylous less than 110 in the case of them. Cholesterol will be low in the case of chylous, where will be more than 200 in the case of pseudochylous. So this will tell you chylomicrons will be present in chylous and pseudochylous less than absent. Because generally chylous efficient, because intestine is the most important organ which helps in absorption of triglycerides from the intestine. So chylous efficient, true chylous efficient will generally have high elevated triglycerides and chylomicrons because they are present there. So that is one more thing that is there. So this is one of the most important thing. So the value of SAG gradient more than 1.435 is invariably associated with the presence of esophageal varices. Generally, we check SAG ratio more than 1. If they suggest of more than 1.435, suggest of there might be underlying varices also. So sometimes while transitive ascites in cirrhotic may be get converted to the exudative. Generally in the pleural effusion also this goes in hand. Generally if you put the patient on diuretics and all, sometimes transitive might convert into exudative because of the free water excretion in the urine. So sometimes transitive exfusion can convert to exudative infusion. Suddenly protein will be high, LDH will be high, all will be high in the case of pleural effusions also. So when the patient is on diuretics, sometimes transitive effusion might be misinterpreted as exudative infusion in the such cases. So always look for any diuretics are there before labeling it as exudative. If the patient is on diuretics, sometimes there is misinterpretation of transudative as exudative. So that is the possibility. And however, it is important to remember that the value of SAG may be falsely low. Sometimes we get low SAG despite of where the very high suspicion of portal hypertension, especially in this patient, especially if there is marked hypoalbuminemia. So in them protein also might be low. So value of SAG may be low, falsely low in the case of hypoalbuminemia, especially when they're less than 2 or something, and hyper gamma globulin when the globulins levels are more than 5 or something, or hypotension is there, or chylous ascites. In all of these cases, maybe SAG might be falsely low. We see a lot of common cases where the albumin is less than 2, or some hypergamma globulinemia is there more than 5 or something. Some patient is in hypotension or something. In all of these cases, SAG can't be interpreted per se because you need to repeat the SAG after improving albumin levels, after correcting the hypotension, whatever is there. So especially in the hypoalbuminemia, hypergamma globulinemia, more than 5 and hypotension, you might need to repeat the SAG ratio and repeat it again. This is one more SAG more 1.435, you need to suspect esophageal varices. And one more thing, when the patient is on diuretic, sometimes translative normal effusion might be repeated as exudative because of the free water diuresis. So this is the management. Most of the cases we see is cirrhosis. So first presentation, always restrict the salt. Salt is the first thing you need to do. Less than 5 grams is, and anything sodium less than 2, salt less than 5 is what we advise. Then start them on spironolactone. At least 100 milligram can be increased to 400 milligram. If suboptimal, then add furosemide. First, always put them on aldactone 500 milligrams. Then, if maximum dose, then add furosemide. Then you add furosemide. Then diuretic response is defined as any 1 kg weight loss per day. If edema and 0.5 kg is less, no edema. So, if there is a weight loss of 1 kg per day, appropriate diuretic response is there. If the 0.5 kg per loss, if there is no edema, patient does not have any edema and all, if the weight loss is 0.5 kg, it is significant, it is a response. If the patient has edema, then at least 1 kg weight loss should be there to call it a response is there. If suboptimal, increase the diuretic intake and all. And also you should do urine sodium. Generally urine sodium should be more than whatever food intake. So there should be negative balance in the body. Sodium should be excreted. So more urine sodium potassium ratio can also be done. So urine sodium should be more than whatever intake we are doing. So there should be negative balance. Then you can titrate based on. You can restrict the salt diet more and more. So one more thing you can do is you can check the MELD score also to prognosticate and all. But most commonly what we do is the urine sodium is one of the important prognostic marker in the CLD patient. So generally urine sodium should be more than whatever intake is there, and sodium potassium ratio can also be done to look for if there is optimal response to diuretic is there. What is sodium potassium response? Always check and let me know. I'll mention it in the CLD chapter, in the CLD discussion again. But do find out what is sodium potassium ratio. How do you monitor in the diuretic response? So then, if generally diuretics can be continued unless some hypokalemia is there, hyponatremia, significant hyponatremia is there, or hyperkalemia is there, or serum creatinine elevation is there, some hepatorenal syndrome or hepatic encephalopathy is there, then you can withhold the diagnosis, temporarily withhold the diuretics, and then if the resolve after resolution, you can start the diuretics again and lowest dose possible. But always restrict the salt diet first to sodium less than 2 grams and salt less than 5 grams. Then start them on aldactone. Go to the maximal dose possible. Then add furosemide. Appropriate diuretic response should be checked with the sodium potassium ratio or urine sodium ratio. Generally should be negative balance. Urine sodium should be more than whatever salt intake we are taking. So this is the case. If any encephalopathy or electrolyte ascitic fluid tap procedure, this is a technique where you press the pull the skin downwards by 2 centimeters. Just mark the skin. Generally, it is done in the left lower quadrant. It can be done below between umbilicus and pelvis also. Sometimes it can be done in right quadrant also, but generally preferred is the left side. So mark the skin and pull the skin downwards by 2 centimeters, and then pass the needle perpendicular. This is called jet track technique. So this pulling the skin downwards will help in the guiding the needle better. So this is a technique, Z-track technique for the ascitic tap procedure. So this is one more thing, what the urine sodium and urine sodium potassium ratio, what I mentioned. Generally anything urine sodium less than 78 millimoles per day after 24-hour urinary collection is suggestive of poor natriuresis. So that means the patient is not put on adequate diuretics. You need to increase the diuretics per se in that patient. So the patient is, despite of being on the diuretics, the patient is not having proper natriuretic effect. So generally adequate natriuretic effect is suggestive of more than 78 millimoles per day. So because 24 urinary collection is cumbersome and all, you can do the spot urine sodium potassium ratio. So the spot urine sodium potassium ratio less than 1 is helpful in suggesting of poor natriuresis, so low natriuresis. That means the diuretic effect is not being enough, or you need to increase the diuretic, or it is not resistant to diuretics or all. So it should be more than 1 for the proper natriuresis and all. So if it is less than 1, there is a poor natriuresis, that is suggestive of bad sign in the patient. So you might need to increase the diuretic dose and all, and that is suggestive of progression of CLD and also renal failure and all. So urine sodium potassium ratio if less than 1, you need to restrict the diet more, you need to increase the diuretics more. That is what you need to remember. So this is the, yes, thank you.